Я почав.
Good afternoon, everybody. Good day, good morning. We Ternopil National Medical University is very happy to welcome Olga Kozyreva, the doctor from medical oncologist from Dana-Farber Cancer Institute from Boston. And thank you very much for your session from Palliative Care. The floor is yours. You're welcome.
Thank you, Oksana, for introduction and welcome everyone. I'm happy to be here and honored to be here and present course of lectures for palliative medicine. So as Oksana mentioned, I'm medical oncologist. I specialize on gastrointestinal and genitourinary oncology, and I also have a special passion for palliative medicine, because a lot of my patients have significant symptoms related to cancer, and with time I developed expertise on symptoms management. I also a consultant for Ukraine Medical Consortium, working with oncologists and from Ukraine, helping with some cases, medication delivery and logistics. And we feel that educational piece also very important to address in this extremely difficult time for everyone. So I really appreciate feedback. If you would like to ask me questions, you can type in the chat box, but I would probably answer questions after I finish presentation, but I may ask you questions as well. It would be good if we have interactive discussion, because I will present couple cases, and I feel the case-based presentation is always interesting and more memorable. So,
dear Olga, if you would need any translation, please let me know, and I will do that.
Okay. So this is the lecture objective. Today we will talk about palliative care in general and palliative medicine in general. We'll chat a little bit about history of palliative care, definition of hospice, difference between palliative care and hospice, history of hospice care, hospice statistic and hospice setting, and indication for hospice. And we will discuss some additional treatments that allowed or not allowed, or welcome or not welcome in the hospice setting. And I will give you also some reference at the end of my lecture. So we will start with definition of palliative care. And palliative care is a relatively new specialty, and it's a lot of confusion even here, especially in providers who is not practicing medical oncology, between what is hospice, what is palliative care. And we giving the lecture to the medical student, we giving lecture to providers, family care physician, primary care physician. We also have a lot of foreign medical graduate residents, or ordinators would be fellows. They coming from countries that sometimes a palliative care conception is just barely exist. Hospice already well known, but palliative care not always there. So palliative care, it's an area of medicine that's specialized on providing patient relief from the pain and other symptoms of any serious illness, no matter of diagnosis or stage of disease. That's a very important statement, that palliative care can be provided regardless of if patients have cancer, end-stage renal disease, end-stage CHF, or end-stage lung disease, and no matter of stage disease itself or how advanced is disease. So palliative care is not intended to provide curative treatment. We're not trying to cure disease itself, but we're rather focusing on management symptoms, relieve pain, discomfort, improve quality of life. This is a very important piece. And quality of life defined not by us, quality of life defined by patient or family. So palliative care also helping with emotional peace, social and spiritual needs of the patient and family. Palliative care appropriate in any age and any course of serious disease. Of course, in my specialty, I deal mostly with oncology patient, and my palliative care intervention focusing on cancer patients. Or sometimes I see patients with benign blood disorder. It's rarely, but they're still eligible for palliative intervention. So palliative care can be provided together with disease-modifying treatment. I mean, chemotherapy, dialysis, radiation, blood transfusion, and surgery, right? We frequently hear the terminology palliative surgery. It means surgery with non-curative intent, right? We frequently hear the terminology palliative radiation. It means non-curative radiation, just focusing on symptoms and pain. So a history of palliative care, it's coming from Europe, and there's a lot of medical and social intervention. It started by a religious institution, specifically palliative care started in France by a group of nuns, belongs Holy Order of Sister of Charity. They started, they established small hospitals, several rooms in a monastery for people who is poor, who is sick, and who are dying without support because they did not have a family to be around and help them with the care. And subsequently, this group of nuns, they opened more than 40 houses around the country that able to provide some simple palliative intervention and also able to provide just a care, just nursing care, and also emotional and spiritual support. So, but palliative care and hospice were considered kind of under one umbrella and was the same until 1974. One of the Canadian surgical oncologist, he invented the term of palliative care to avoid negative association with word of hospice, because hospice still can be very scary word, and because it's definitely associated with end of life, and it definitely associated with death, and some people have a very negative impression about hospice. Here it's very common. In some big medical institution, instead calling hospice and palliative care, they call this team symptoms management team. Try to remove hospice and not focus on negative association. But it's still a big debate inside hospice community. Is it prudent to remove hospice word? Because we should be open and talk about dying and death openly rather than try to mask it. So the first palliative care clinic, hospital based, was open in Cleveland Clinic, one of the oldest clinic in the country, 1987. It's not very long time ago. And now in the United States, we have approximately 1,400 palliative care program. And about 80% of hospital with hospital bed, more than 300 hospital beds, they have palliative care. And actually, presence of palliative care program is a measurement of quality of care. It's proven that it's decreased length of stay and improved quality of life, not only for patient, but also it's important for staff who is taking care of this patient, because staff can be in significant emotional and moral distress if they don't have appropriate support from team who is knowledgeable how to manage symptoms and how to address social distress and spiritual distress. So we have about 50 training palliative care program. It's usually 1 year of training after family practice, internal medicine, neurology. We have several programs that combine hematology, oncology, and palliative care. The combined program usually 4 years of training. After internal medicine, after 3 years of internal medicine training. As a specialty, palliative care was approved and part of American Board of Internal Medicine only since 2006. And now it's required training and passing exam. Even you in field of medical oncology and constantly dealing with symptoms management, with palliation day-to-day, I would be not eligible to take a palliative care board. I need to have extra year of training. So why and when is palliative care beneficial? So I think this is a very important slide because the first part of the slide on the top is reflecting our old approach to serious diseases. So when patient diagnosed with serious disease, we focusing on disease-directed care, right? It can be chemotherapy, it can be management, patient with HIV, with antibiotics, it can be CHF, congestive heart failure management, or end-stage renal disease. And then only tiny amount between patient getting disease-directed care. In the end of this, when patients start getting worse and they have more symptoms burden, we offer some palliative care intervention and eventually switch patient to hospice care. So, and you can see on the arrow, we are missing opportunity for palliative care, and we're missing for opportunity to improve patient family quality of life. And now we're moving more in a new model when palliative care can be introduced in the early disease stage together with disease-directed treatment. Basically, we introduce palliative care on time of diagnosis, and frequently on time of diagnosis, cancer diagnosis in my case, we try to offer palliative care right from the start and addressing symptoms management aggressively. So, and if we do this, we improve patient satisfaction, we decrease patient suffering, improve communication, and patient would be ready for hospice and more acceptive to hospice. And also palliative care and holistic care for the patient family happen even after dying. We usually, we call this bereavement, and we usually meet with the patient. We have social worker, we have chaplain, we have priest, we have bereavement consultant who continue to see patient family and talk to the patient after patient death. And sometimes we do meetings with a team and talking about and invite family member. We doing this, many hospices actually doing this about every 6 months. It's memorial meetings. It's very helpful for patient family to who is still grieving, who is still in bereavement process. And it's also very helpful for the team because to be in hospice and take care of dying, it's not easy. It takes a toll from us and from the nurses. And any good and big hospice, they can be working together with palliative care. They have a social worker who have decompression session and stress relief session with the nurses and physician and the social worker. It's also very essential, because if you're not able to heal emotionally, it's very difficult to give back and take compassionate care of patient. So multiple studies done about palliative care, that it can improve quality and significantly lowering the cost. And as you know, in the United States, we have great statistic and ability to do clinical trial, ability to calculate the cost of care. And it's also a reason why if patient is admitted, the cost of stay and length of stay with a palliative care consult on board and actively follow patient will decrease by 28%, and rate of readmission will decrease to 48%. So if patient is outpatient working with palliative care or following palliative care clinic, the rate of admission to the hospital decreased by 50%, and rate of ER visit decreased by 35%, emergency room visit decreased by 35%. So if patient lives in nursing home and they have palliative care team follow, its decreased rate of hospital admissions and ER transfers by 43%. So if patient receive home-based palliative intervention or then hospice, it significantly decrease total cost by 36%. And it's enormous amount of money can be saved for patient who doesn't need to be admitted, whose symptoms can be managed at home with guidance of the nurses, guidance of physician. And these beds in the hospital can be preserved for patients who really benefit from acute symptoms management or acute disease management, who needs to be in acute hospital and cannot, that this intervention potentially cannot be done at home. So for me personally, I would consider a big failure if my patient with advanced cancer die in an intensive care unit, because it's mean we not work enough with the patient family, because majority of patients prefer to die not in intensive care units, they prefer to die at home, or because we have so many nursing homes in the United States, a lot of nursing home residents dying in nursing home because this is home for them. So, and where palliative care can be provided? It can be provided in the hospital as a consult service. It can be provided as outpatient, can be clinic-based. It can be based at patient home or in as a community service. So outpatient, purely palliative care, it's relatively rare. They usually working together with hospice, and they have palliative care department in the hospice. In academic center, we have a palliative care academic clinic. We do send patients there, and I can describe a couple specific situations when we ask outpatient palliative care to help us with the management. For example, if patients have really difficult control symptoms, severe pain, severe emotional distress, poor coping, obviously all young patients with incurable disease, all children will see palliative care clinic and doctors during disease course. So another example, if I have patient with active cancer who require active intervention, high dose of opiate, and they have concurrent history of opiate use disorder, any substance use disorder, psychiatric disorder, we call this double diagnosis, dual diagnosis. It's helpful for me to have extra pair of eyes to help with this patient management and make sure that we not undertreat them and we not overtreat them, and that they safe at home, but still we have good symptoms management and good pain control. So, and I will start with 3 cases. This is my real cases. It's a lot of internal medicine here, but you feel free to ask questions and I will ask questions to you. So I have a 97 years old woman. She is originally from Odessa, and she is probably about 30 years in the United States. Her daughter is 74. She is she's totally mentally normal, and she has no dementia. She has excellent memory. Because of long life expectancy in the United States, a majority of immigrants from former Soviet Union, they pretty computer educated. It's not uncommon. I see 90 plus years old. They sitting with the tablets and watching TV or listening news. So this patient has chronic anemia due to gastrointestinal bleeding. Secondary to disease, we call this disease watermelon stomach. You can see on the picture, it really looks like a stomach, but not green background. So we call this disease GAVE. It's called abbreviation gastroenteral vascular ectasia. And basically all her stomach, you hear?
Yes, yes.
Oh, yeah. All her stomach have a small telangiectasia, and she's bleeding. She cannot tolerate any NSAIDs, non-steroid anti-inflammatory medication. And sometimes she coming to clinic with hemoglobin of 60, but usually she is around 90. She also have a chronic kidney disease, stage 3. She has B12 deficiency, and she has bad arthritis. So, and how to manage her arthritis? She's 97. It's bone-to-bone arthritis. We try steroids injection. It's not working for her. And as I mentioned, she is not able, because of her stomach condition, using anti-inflammatory medication. So, and she's on palliative intervention. She's on palliative blood transfusion. She's on palliative iron infusion. She's received erythropoietin, and she's receiving B12 injection. So, and she's on small dose of hydromorphone. It's opiate, because she's not able to tolerate any Celebrex, aspirin, Tylenol, because of her stomach. So if we stop this palliative intervention, she will die, because her hemoglobin slowly will go down, and she will develop CHF, and she will die from anemia. So I'm treating her for many years, and she sometimes comments that it's enough, I'm old, but still she would like to go, and we talk about her goals, and her goals, recent goal, I would like to survive until the victory. See, she's, you know, crying sometimes, watching Fagan and Aristovich on her tablet. So, and talking to other my patients. So what we did for this patient, we just provide palliative care. Obviously, I cannot cure her anemia. I cannot cure her CKD, chronic kidney disease, and I cannot cure her arthritis, but I can palliate her symptoms and I can give her good quality of life. So, and case number 2, also my real patient. So he's 56 years old, otherwise healthy. He loves to fish, and he works in construction. He presented in the hospital with shortness of breath and cough, and he had blood in his urine. He has significant weight loss, but was healthy otherwise. And when I saw him in my clinic at 4 p.m., so he was just discharged from the hospital with new diagnosis of metastatic kidney cancer. So, and he's extremely short of breath, sitting in front of me. So, and this is his CAT scan, and this is his chest X-ray. So, kind of self-explanatory, right? What would you do? I don't know if any medical student or resident would like to tell what palliative intervention we can do at this point.
Can anybody answer what palliative care could we do? Oxygen therapy, non-invasive. It's my variant.
Good. So it's available, right, around the globe. Yes, we'll give him oxygen. And also I can see, and I can feel he has, yes, he has pleural-based disease, but there is a pleural effusion on the right side. And he has such a limited respiratory reserve that even small drainage of pleural effusion can provide some palliation of his shortness of breath, right? But we need to treat his cancer. So, one patient asking me, Dr. Olga, because no one can pronounce it, my last name, how bad is my cancer? How much time I have? This is normal questions. Can I make it until next fishing season? And he told, I'm really short of breath and barely able to walk. Can you make me better? I told, for sure, we can make you better. And we give him oxygen in clinic. I call my thoracic team and pulmonary doctor and thoracic doctor and told, guys, can you drain him now? Because I need this now. I don't want him to be readmitted to the hospital, because if he readmitted to the hospital, I would not able to treat him, because the treatment for metastatic kidney cancer, it's usually involve immunotherapy. And immunotherapy, I know Keytruda is available in Ukraine. I have several patients from Ukraine who is receiving Keytruda. We transfer their care from Ukraine to here. So, and it's available for several years already. So, of course, it's very expensive. I know in Ukraine it's about $4,000 per injection, and here it's more expensive. It's about 5 times more expensive. So, but not for the patient, for the hospital, and hospital would not administrate immunotherapy inpatient. So when he's asking me about his prognosis, I just tell, listen, I don't know what your prognosis, everyone is different. I just pull the graph is Kaplan-Meier overall survival in patient who treated for metastatic kidney cancer. And I can share with patients that there is about 74% of chance that he would be alive in 24 months, in 2 years. But I tell the patient, I never know, you will be in 74% or you will be in 26%. This is honest, and it's relatively easy for patient to understand. And green line is Keytruda, pembrolizumab in combination with medication called axitinib. It's TKI, small molecule inhibitors, tyrosine kinase inhibitors. And so, can you make my symptoms better? Absolutely, we can make your symptoms better, and I would be ready to treat you tomorrow. So we gave him oxygen in clinic. We did palliative thoracentesis. We removed about 750 cc from his right pleural cavity. We got hotel for him across the street because he needs oxygen. I don't want him to travel too far, and I booked him for pembrolizumab Keytruda infusion 9 a.m. next morning. So, and I did not admit him to the hospital. So he did well. So he called me next week and told, listen, I'm better. So, and I was very, very happy that he is better. And I was pretty confident that it's already some Keytruda start working. And we were working to get oral pills for him because with his disease burden, you know, he was kind of on the verge of being intubated and have high oxygen requirements. And he told me, my cough is improved. I am less short of breath. So he came to see me in 3 weeks. He's definitely better. I told, I don't need even chest x-ray to see that you're doing better. He started eating. He's talking to me with no interruption. He's visibly less short of breath. So couple cycles after we start Keytruda, he coming to see me and I asked, what is bothering you? He told me, oh, you know, I was hiking over weekend and now I have knee pain. So, and this is his chest CT. 2 years later, he almost in complete response. And now he is about 8 months off treatment. We stopped treatment because we feel that now Keytruda is not contribute a lot and it's expensive. He tolerates treatment very well. He still have primary kidney tumor in his body. And I did PET scan. His PET scan was negative. There is no uptake, and we feel confident to do surveillance, and I probably do surveillance now every 3 to 4 months. And of course, he knows that he should see me, see us anytime if he has any new symptoms. So looking back, when I saw this horrible imaging, right? My intention was palliative treatment, palliative oxygen, palliative pleural effusion removal, thoracentesis, and palliative immunotherapy in combination with oral TKI, right? But he did well, right? But palliative intervention was very appropriate, and now he doesn't need any palliative intervention. So rewarding case. So the third case, also very interesting. I'm very proud of this case. I was involved with several of other colleagues. So I was called for the consult in the hospital. It was an elderly gentleman laying in the bed. He had chronic kidney disease, but otherwise he was healthy for his age. He presented with gross hematuria, and he was diagnosed with upper tract urothelial or transitional cell carcinoma. And except mass in his ureter on a junction of renal pelvis, he has no metastatic disease. His hemoglobin was 7.2. He had three ways urinary catheter, which is pretty painful and uncomfortable because it's a big diameter of the catheter. So, and he was on continuing bladder irrigation because of clot, because of bleeding, and he was not even able to walk because he had this bag with it was basically drip with normal saline, and he was attached to this catheter, and he was not able to move normally, even go to the bathroom. It was very uncomfortable, but mostly due to Foley catheter. So, and all his desire was, let me go home. So, and look, when I looked to this picture, I didn't know how we can let him go home with all what is going on, especially with catheter. So, but somehow, with urology help, with bladder irrigation, we able to stop his bleeding. So we treated his anemia. We give him a couple units of blood. We discharge him home with just Foley catheter because nurses, at least if he start rebleeding or develop clots, are able to irrigate his bladder at home. We got him nursing services at home. We sent him for physical therapy. We stop all non-essential medication. We stop his aspirin, cholesterol medication. We stop his blood pressure medication. So we give him tiny dose of oral iron and also give IV iron in clinic. So I requested radiation oncology consult just to target this spot in his kidney. And we have to remember that he had chronic kidney disease. I didn't want to put him on hemodialysis because his creatinine already was about 2.1, 2.5. I don't know how in Ukraine, how you measure creatinine by American or European unions?
As I remember, millimole per milliliter.
So, and slowly his hematuria resolved. And I requested radiation oncology consult, and after very careful discussion and consideration, he was selected to receive a pretty novel treatment. It's MRI-guided stereotactic body radiation therapy. It's called MRI-guided LINAC SBRT. It's really a very cool technique. It's very precise. You can really do radiate very precise area with such a confidence that you will not ruin or you not affect tissue around, because yes, he
Could you switch off the microphone?
Okay, we're good? Hello?
Yes, yes, thank you, sorry.
So, and when he finished this radiation treatment, it was only 5 days of radiation. So, and his hematuria resolved. He worked with physical therapy. His hemoglobin now 108, and his creatinine is near normal. He lives at home with extended family, and he's still cooking for himself. And this is me and him, and he's 105 years old.
Wow.
So 105. It's so rewarding to see, and of course, I don't know what he eats, but he looks like he's 80. Like physiological age, it's definitely less than his Italian gentleman, and he was born 1917, 105 years old. So we're planning to write a little case report about a complex management of geriatric patient. So all we did for him was palliation, right? We're not trying to cure his cancer. We're trying him get home and be comfortable with his family. And with this intervention, it was achieved the goal. He's happy, smiling, singing for me when I see him. So now I would like to focus why doctors here in the United States refer to palliative care. Usually it's difficult physical symptoms, pain, nausea, vomiting, anorexia, fatigue, insomnia, dyspnea, cough, name it. Hiccups, intractable hiccups can be very difficult to manage, bad diarrhea, bad constipation. So in oncology, because we deal with the symptoms all the time, we less refer to palliative care compared to internal medicine doctors, family practice. So, or cardiology, or patient, or a pulmonary doctor. So psychosocial symptoms, usually palliative care has a social worker on the team. Referral can be made based on distress, demoralization. Requesting care is that it's not indicated. I have one patient who is admitted now, full of metastasis from colon cancer. Patient family requesting liver transplant and asking transfer me to liver transplant center, which definitely not indicated. So anxiety, depression, delirium, it's another indication for referral to palliative care. So difficult decision-making, it can be coming from patient, family, physician as well, because sometimes treating doctor can be in significant stress. They feel that they're not able to provide adequate coverage of the symptoms, and there is a tension between different family members. And obviously advanced care planning. Advanced care planning, hard to find healthcare proxy, patient completely alone, dying, and we need healthcare proxy substitute. He's not able to participate and make a decision. And nuances about court status. And court status, you probably familiar with conception, do not resuscitate, do not intubate. So that's also important from legal perspective and from medical perspective. Okay, when to refer? Another indication, multiple hospitalizations, difficult to control emotional symptoms due to serious medical illness, patient and family uncertain about prognosis of goals of care, request care that is not indicated, and actually patient or family member can request information or can request hospice referral. I had one kind of very memorable case when I saw patient with stage 2 or 3 colon cancer, and he was alcoholic. He was 56 years old, and he had tumor which was knee obstructed his colon, and he told me, I don't want to be treated. I told, how come that you don't want to be treated? We can cure you, or at least we can do palliative colon resection. He told me, no, can you give me referral to hospice? I would like to continue my lifestyle. I don't want to go to the hospital to have surgery. And we had a family meeting, and he was competent to make this decision. And we refer patient with potentially curable disease with life expectancy of more than several years to hospice because of his request. So another important slide, and I place this article link in the end of my presentation. So it's one of the seminal article for palliative care and early palliative care intervention. It's actually, if you introduce palliative care early and combine palliative care with direct, with cancer, in this situation, it was lung cancer, with disease direct care, with chemotherapy, palliative radiation, it's improved overall survival, but almost 2.5 months. And you can see the graph there, and people who receive palliative care plus standard of care. SOC stands for standard of care, but early palliative care was introduced. They survived 11.6 months, and they had better quality of life, and they have less hospitalization, and they have less distress and family satisfaction compared to patients who just receive standard of care alone. It was 11.6 versus 8.9 months. So the difference, 2.5 months in oncology, now it's not very significant because we have such a powerful medication. But a lot of time, you will get medication approved on this difference in overall survival. And it's pretty impressive. And behind of this, it's a huge saving money for the hospital, for society, improve quality of life, and improve life expectancy. And sometimes when patients run out of treatment options, they ask me, do I have treatment options? I tell, yeah, you have. You can be under palliative care, and statistically, it will improve your quality of life, and it can prolong your quality of life, especially when we combine this with standard treatment in the beginning of chemotherapy. So this was published in 2010, and a group of the doctors from Massachusetts General Hospital in Boston. So now I would like to talk about difference between palliative care and hospice. Many of doctors still believe, and nurses and providers, that palliative care is appropriate only when nothing more can be done to treat patient disease and prolong life. So you saw example, and it's not true. So unlike hospice, palliative care can be and should be delivered while patient continue treatment for their disease. It can be cancer, CHF, congestive heart failure, or HIV/AIDS. HIV/AIDS, it's a special population. They suffering from multiple symptoms, and they tend to be undertreated, especially pain, because frequently they can have social stigma, and they can have a history of drug use disorder. We try to pay attention to the symptoms management and try to refer them to palliative consultation. So, and this is a good picture reflecting relation between hospice and palliative care. So they overlap, they definitely overlap. They have somewhat overlapping goals, right? Relieve suffering, improve patient quality of life. But hospice, it's more improve patient quality of life and trait of quantity of life. But palliative care are much broader. And I wish that we start all patient and introduce palliative care earlier. So now we will focus on general principle of hospice. And hospice, it's not a place, it's just philosophy of care. Focus on compassionate, holistic end of life. Patient will still have autonomy and decision-making, what they would like to do if they able to make a decision mentally. So care directed by the patient and family, and dignity and respect for patient and family is a huge part of hospice care. And goal of hospice, good quality of death. So, and it's, I feel it's very satisfying when my patient has had good quality of death, or has good quality of death. Yes, it's very it's great when I'm able to help the patient. It's great that I'm able to see my 105 years old going on 106 years old. But to see good quality of death with, you know, reasonable distress, with grateful family, with no pain and the end of life, it's also very, very rewarding. And bereavement is care after death for the patient family. It's a kind of separate topic, usually done by social worker. We can try to explore how to talk about bereavement. I don't know if bereavement services existed now in Ukraine. So history of hospice movement is important. Hospice was evolving since 11th century, and it's coming from Latin word hospitium, which means hospitality. And word host, hotel, господин, hosting, hostel. So it's from one Latin word, I mean relation of a host and guest also close to this. So a hospice movement started in the United States and came from actually from two British physicians. One British doctor who was social workers, and she graduated nursing school, and then she became a doctor. Her name is Cicely Saunders, and another doctor, psychologist, Elizabeth Kubler-Ross. So Dr. Saunders founded the first modern hospice. It's still working, hospice of Christopher in London, England. So, and it's interesting story behind. You probably can go to Wikipedia and read about the Cicely Saunders. She was absolutely incredible woman with a lot of compassion. And a lot of influence in medical community, and still have a lot. She passed away in 2006, I believe. So the first hospice in America was opening in Massachusetts in 1974. And about 1980, US Congress created legislation establishing Medicare coverage for hospice. It's covered by governmental insurance, and all insurance is covered by, all hospice care will cover by insurance. So, and I Googled first hospice in Ukraine was opening in 1997 in Lviv city hospice, still working. And first pediatric hospice opened in Ivano-Frankivsk in 2013, and it's oldest pediatric hospice now. So some statistic and setting, we have more than 3,200 hospices across United States. Some of part of healthcare system, some of independent, some hospices for profit, some hospices non-for-profit. So we have about every fourth American dying, they will die with hospice services. It's about 600,000 die every year, and 1/4 will die with hospice service. A hospice can be inpatient home. Majority of patients will prefer die at home, but for to be at home, they need dedicated caregiver, because hospice nurse will visit them and guide patient care, but they will not stay in, or hospice volunteer or assistant, they will not stay 24 hours. So it's usually required dedicated caregiver. It can be a family member. I had people who, immigrants, family there, and there is they totally alone. It's in United States, and they hire private pay to stay and be sure that they're dying at home rather than go to nursing home or dying in a hospital. So nursing home residency, because we have a lot of elderly population, and they usually die in nursing home when time. So acute hospital setting, yes, we have patients who die in the hospital on hospice. Usually this patient have a very short life expectancy or significant symptoms burden require skilled intervention, right? For example, they pain so badly, so bad that they need to be on high dose of morphine drip, or they have poorly controlled seizures and they need to be on propofol, Precedex in order to control seizures. But it's not very common that acute hospital setting they die. So some big and academic hospitals, they have palliative care unit. Usually it's non-for-profit unit, and patient can die there. Frequently it's young patient who needs a lot of support, and they can be discomfortable at home. They don't want to be their kids around with them suffering. So we also have residential hospices. Residential hospices is we call hospice house. It's frequently just a big residential multi-family house. We preserve for symptomatic patients. They have staff by the nurses and assistant, physician available for the consultation, for symptoms management if needed, but majority intervention done by the nurses, and they're extremely skilled. And if my patient on hospice, nurse calling me, I trust nurses and we work together, and frequently they know better than physician how to manage end-of-life symptoms. And so eligibility criteria for hospice: life expectancy less than 6 months, poor performance status, plus one of the following: end stage COPD, chronic obstructive pulmonary disorder, end stage congestive heart failure. Sometimes they require drip, and Lasix is okay on the, and even Lasix drip sometimes can be done on hospice with palliative intent. So bad ischemic heart disease, incurable low ejection fraction. So neurological disorder, including stroke, advanced Parkinson's disease, dementia, ALS, multiple sclerosis, renal failure, failing or not able to tolerate dialysis or declining dialysis, chronic liver disease, cancer, HIV, dementia. So refractory autoimmune disorder, refractory lupus or rheumatoid arthritis. So bad infection, TB, tuberculosis, or sepsis. Because I'm seeing a lot of patients with gastrointestinal malignancy, frequently we send patients with biliary cancer, with complex biliary anatomy, multiple stents, they dying from biliary sepsis. And we know that sometimes they be admitted and sepsis can be reversible, but there is, when the disease progressed, eventually they will die from sepsis on hospice. So despite we doing every year better in the United States to refer to hospice and palliative care earlier, but still service is not completely utilized, and the medium time to be on hospice until the death, it's about 2.5 months. So my longest patient on hospice, she was 2.5 years on hospice, and she had breast cancer, and it was metastatic, but she was on tiny dose of hormonal pills, and she survived 2.5 years, and she she didn't get admitted to the hospital. It was pretty comfortable 2.5 years. Our patient on hospice can travel, and sometimes we get a request, I would like to go to Las Vegas. How you can make this happen? So absolutely, Las Vegas has excellent hospices, and some people would like to go and game before they die. And we sign out, we call hospice in another state and tell, my patient is coming, can you accept for care? And they will accept and connect with the hospice team and transfer the care. So what can be done and what cannot be done on hospice, right? Majority of hospices are not allowed chemotherapy because hospice focusing on quality rather than quantity, and focusing on symptoms, and chemotherapy not allowed. Sometimes they allow palliative chemotherapy, but case by case, insurance will not pay for both. However, pediatric hospices allowed chemotherapy while on hospice. So we try to put all catheter if needed, catheter for paracentesis, thoracentesis, pericardiocentesis should be placed prior to hospice admission if possible, because it's not great if my patient have ascites and for the drainage I need to go back and forth to drain in emergency room, rather than patient have a tiny catheter in the abdomen, and it can be done bedside by hospice nurses. It's relatively easy intervention, and it can provide comfort and can be done on as needed base. So I remember one of kind of difficult case. I took care of 18 years old girl who had a rare liver cancer. So, and she was dating, and we treated her, and she coming to me and tell, listen, I have date today. Can you drain my ascites? I cannot zip my jeans, and I need to be skinny for the date. So difficult, but that's life. So blood transfusion can be offered on hospice, but it's costly because hospice will pay, at least here in the United States, for any additional intervention. And now community, especially hematology community, blood specialists talking about that blood transfusion is palliative, can decrease shortness of breath, can improve fatigue. It's palliative intervention, and it can palliate, it's improved quality of life, especially for patients with hematological cancers, because if you stop transfusion, they die. So yes, it's possible, but it can be costly and matter of negotiation. So total parenteral nutrition, TPN, can be offered. I have patient on hospice with TPN. Yes, she had non-functional bowel because of peritoneal canceromatosis due to gastric cancer, but she survived 8 months. She was gardening with TPN. IV hydration usually discouraged, but can be offered. It's not very expensive, but it's usually not improve patient quality of life or outcome. Anticoagulation is a very common question. So what to do with Lovinox? What to do with rivaroxaban? What to do with heparin? So we continue anticoagulation if patients have symptomatic pulmonary embolism or DVT. If patient has no symptoms from PE DVT, we not continue anticoagulation. Sometimes this patient have atrial fibrillation. We can continue anticoagulation to prevent stroke. So non-essential medication we usually discontinue. So in oncology, especially when patients have life expectancy less than a year, we try to discontinue non-essential medication. We try to discontinue all statins, atorvastatin. We try to discontinue PPI, proton pump inhibitors, unless they have really GERD symptoms. Vitamins doesn't make any sense. And we try to decrease amount of pills they're taking. So, and now I would like to talk about Hospice Comfort Kit. Hospice Comfort Kit, it's basically the simple kit of medication which would be sent to patient home or bring to patient home by a hospice team. It's very basic, it's very cheap. It consists of liquid morphine when patient not able to swallow a pill. A family can give liquid morphine under the tongue. It's liquid lorazepam, benzodiazepine class of medication, liquid or tablets can be given under the tongue. So for anxiety and agitation, it's also have levzin. It's medication similar to scopolamine to decrease excessive secretion. When patient dies, can happen, dying during the dying process. So we also use Zofran and Dansetron. We have sublingual dissolvable pills can be given under the tongue. So we have Tylenol suppository. If patient have fever, it's easy to administrate. So, and we have simple medication for constipation, suppository with bisacodil. So it's really inexpensive pill and inexpensive medication, and family with nurses' guidance will able to provide comfort and manage simple symptoms. Especially during the night, if patient in distress, agitated, have pain, morphine and lorazepam can be administered by family member. So again, I would like to repeat this slide. The palliative care overlap with hospice, but it's not equal. There is a significant difference between two of this setting and intervention. So, and I would like to finish my lecture with quote from Hippocrates that cure sometimes, treat often, and comfort always. So I wish we have more cure, but comfort should be always provided regardless of disease stage or patient condition. So, and there's a slide, palliative care resources, very helpful. There is presentation, there is guidelines for palliative care. There is information how to deliver bad news, how to communicate with the patient and family. So, and this is an important article to read about early intervention and introduction of palliative
Марко,
care.
я собі відкрию зараз, хвилинку.
That's it. I finished. Thank you. And I'm happy to answer questions.
No, first of all, I would like to thank you. That's impressive. I'm really impressed by the cases you mentioned. That's very nice. People can live longer, people can live better. That I think everybody wants to his, her family. That's great. Thank you very much.
Thank you. Thank you. So if any student or faculty have a questions, yeah, you can text me or ask directly.
Please, anybody, could you? You're welcome.
May I ask a question?
Yes, please.
Yes. Dear Olga, thank you very much for your presentation. And I have a question for clinical case number 2. It's very interesting. Did you make a PDL test before treatment by Keytruda?
No. In kidney cancer and in RCC, it's not required.
And tell me, please, what happened with the primary kidney tumor?
Primary is still in. I can send you. I can send his you recent CAT scan. We didn't touch his primary. Primary is responding, and we're using immunotherapy a lot because it's available. And I'm so impressed by medicine here. I have like many immigrants from different countries, and not an issue to get Keytruda. Now I'm treating one gentleman from Kiev, also difficult emotionally case. He was diagnosed with stage 3 melanoma on his right shoulder. So pretty big scar removed. He had lymphadenectomy. So, and his main worry, he cannot go and, to the war, right? Because he cannot function normally. He cannot hold the weapon because of lymphadenectomy. He still did not gain a full range of motion. So, and he came, we got insurance for him because it's a great support here. And we started Keytruda within 10 days when he arrived. And he's getting this adjuvantly. So I have a whole collection of patients because we use Keytruda so often who in complete response. It's unbelievable. Some of my radiologists, they crying when they see the cases. They calling me, Olga, what did you do? I cannot believe that it happened, right? Because that's real. So, and absolutely, I'm happy to do talk about immunotherapy toxicity and review cases regarding Keytruda or any immunotherapy. Yeah, if you guys interested.
Thank you.
So yeah, it's very rewarding. We have another pretty remarkable case. It was about 5 years ago when Keytruda got approval for lung cancer. So young guy, maybe 52 years old, non-small cell lung cancer, pretty advanced, failed 3 treatment line, basically almost no option left, shortness of breath, recurrent pleural effusion. So we gave him Keytruda and he got admitted with some decompensation, and then from the hospital, he was discharged to hospice. So 6 months later, hospice calling us and tell, can you revoke and stop, cancel the hospice order? We told why. So patient is resurrected and planning go back to work. So, and we revoked hospice order and he went back to work. He survived for another 2.5 years. And so that's it. Thank you so much. And I'm available. You can email me.
Olga, I'm very sorry. Just a second. We have one question in our chat from our student, from Lukas. Does this branch of medicine and working with terminally ill patients put extra strain on the doctor's physical state of health compared to other branches of medicine, in your opinion? Is it for everyone?
That's a very common question we are getting when we work as a medical oncologist or surgical oncologist. Yes or no, right? Of course, it's difficult emotionally, but it can be very, very rewarding, right? When you can extend life, get a good quality of life, when you can get good quality of death, you need to be in a good spiritual health, emotional health, and know how to recuperate. This is essential. I remember one case when new hospice got open. And to get to the hospice business, it's not easy, and you need to have certain experience. And they just they hire nurses. They had no experience in care of dying patients. So, and nurse got so attached to the patient. When patient died, she called me, and she was crying. She was crying. She was not able to stop crying. I told, oh my God, what to do? Do you have social worker? Because you need sometimes sit with a patient. You need to sit with providers, and just even talking about patient, how wonderful this person was, it can be very helpful, but you need time to process. You need time, emotional time, to process this emotionally and physically. And if you're not doing this, you will burn out. So big hospices, they have internal social worker when they helping to process with the team, because yes, it can be difficult. So another important piece, there is a conception of therapy called dignity therapy. And dignity therapy is, I can send a link to article. Basically, when patient on hospice, sometimes they paint, sometimes they write a card for the future. They can write congratulations with a birthday, with wedding, for many years in advance. Sometimes they write culinary recipe. They do recipe book for the children, for the grandchildren. We also have special books for the kids that, for example, grandma or grandpa can read this book and record the voice when they're on hospice or just old or dying. And this book with the voice can be given to next generation or to the grandchild. So very interesting kind of area of therapy, improve patient quality of life, decrease distress, improve family satisfaction. And it's good for provider to see that it can be done. But every case is different and every provider is different. So, but you have to provide support for the doctors as well, who is working with terminally ill patients.
Oh, thank you very much. You know, it's very nice that dignity therapy, it looks so humanity, and I am pretty sure that will give a lot of joy to the relatives. Lucas, please let me know, are you satisfied? Did anybody? Yeah, he wrote, of course. Thank you. Thank you very much for the really brilliant lecture. It's a lot of things we can do for such category of patients, and I'm very happy that today you told about these moments for us. Thank you very much.
So, and thank you for letting me give this talk. And I know it can be very thought-provoking from many dimensions, right? And from medical part of this, from psychological part of this. So I will see you in 2 weeks. And I'm planning to give in 2 weeks pain management lecture, okay? So, and if someone email me briefly what pain medication available in Ukraine. Just, I know that morphine is available, fentanyl patch is available, what else? Like common medication, tramadol is available. Would be great because I can focus on these medications.
Great, we will prepare this information for you. Igor Josipovich, Nadia Ivanina, we are able to do that, I think.
Yes. Available
Thank you.
oxycodone, buprenorphine, plus oxycodone,
Butrans,
buprenorphine, codeine phosphate, codeine.
Okay.
Yeah, thank you.
Oxy, okay, morphine, okay. Thank you. Bye-bye now. Bye-bye, thank you so
Bye-bye.
much.
Thank you
Thank you very much.
for your lecture. See you next lecture.
Yeah, до побачення.
До
Bye-bye.
побачення.